much. It's certainly a great honor for me to be here, to be asked to preside over what should be a very engaging evening of discussion. I was asked when I came in if I was an alumnus of Ottawa U. I consider myself to be an honorary GG. I took a couple classes here in the 1990s, and my father taught and worked here for 36 years. So I spent a lot of time on the campus, and I've seen it change over many, many years. So I feel as if I belong to this institution. I have a confession to make that will probably not endear me to a room full of, well, comprised of at least, some neuroscientists and psychiatrists and people who are interested in the brain, because if truth be told, I've spent very little time in my life thinking about my own brain. Those who know me well have often likened me to the Scarecrow from the Wizard of Oz, and questioned whether in fact I have one. But as someone with very poor eyes and belonging to a family with an unfortunate history of blindness, my grandfather and my cousin went blind, I spent a lot of time thinking about my eyes. As an asthmatic who's had a couple of attacks, I often think about the state of my lungs. But my brain, not so much. Out of sight, out of mind, I suppose. Perhaps because up to now I've been fortunate not to sustain any kind of brain injury or suffer from a brain disorder, my brain has often seemed an entity apart from me, a bit of an abstraction. Close friends and family members, though, have not been so lucky. One of my very, very good friends suffered terribly from depression and committed suicide about 10 years ago. This year is actually the 10th anniversary of that. But for those folks who do have to think about their brains, and for many Canadians, the debate we will have this evening is not just an academic exercise. It is a conversation that is intensely personal because it is about their lives. Many of you, I'm sure, have seen the literature. 50% of all families in this country, about 15 million Canadians, have had a brain disorder impact their family. Like many of you in this room, I am one of those 15 million. Within the next 20 years, brain disorders will become a leading cause of death and disability in Canada, which is an astonishing and sobering number. According to Health Canada, the economic burden of neurological and psychiatric diseases is estimated at 14% of the total burden of disease, or $22.7 billion annually. Thankfully, we are now talking about the issue of depression. Of course, there was a time, and I'm old enough to remember a time when talking about depression was taboo. And I really salute the Institute for bringing us together this evening so that we can have this conversation. So I just wanted to present you with those facts and figures, and hopefully that's put this discussion into a bit of context. We've assembled, as you can see, a crack crew of scientists who will be debating the following question. Are today's use of antidepressants overprescribed and ineffective? Taking the stance that antidepressants are overprescribed to the detriment of some patients' recovery is Dr. Hazen Gandy, Associate Professor in the Department of Psychiatry, he's on the left here, and Head of the Division of Child and Adolescent Psychiatry at the Children's Hospital of Eastern Ontario. He's also from the East Coast. He's from New Brunswick, where they don't seem to know how to count votes. We won't hold that against you. And Dr. Simon Hatcher is the Vice Chair of Research at the Department of Psychiatry, Faculty of Medicine at the University of Ottawa. He hails from the same country as the reigning winner of the Booker Prize, the author of The Luminaries, and he's a luminary himself, Eleanor Catton. You should read that book, The Luminaries. But please welcome both Dr. Hazen Gandy and Dr. Simon Hatcher. Countering their argument will be Dr. Pierre Blier, Professor of Psychiatry at the Faculty of Medicine here at the University of Ottawa, and Canada Research Chair in Psychopharmacology. I told Dr. Blier that he seemed to be a very, very good man. And then he told me he was from McGill, and it all made sense. He taught at McGill for many years. Joining him is Dr. Richard Bergeron, a psychiatrist and neuroscientist with the Ottawa Hospital Research Institute. And, well, we're going to get to know each other in the next hour or so. Dr. Blier and Dr. Bergeron will argue that antidepressants are extremely effective, not overprescribed, and necessary for many patients' long-term recovery. You, the audience, will have the opportunity to ask questions, and at the end of the evening, you will vote on the best argued point of view. No one is going to be voted off the vote, though. It's not that kind of program. It's not that kind of program. So we are going to begin. The opening statement will be made by Dr. Simon Hatcher. Each debater will have 5 minutes to make their argument. We're going to have a freestyle debating round where all of them will get into the ring and engage in fisticuffs. But my job is to be the proverbial referee tonight. You will also have an opportunity to pose questions and make comments. We would ask, though, that you respect the fact that we only have a certain amount of time, limited amount of time. We're going to try and get as many people to speak as possible. In this capacity, I serve as the judge, jury, and executioner when it comes to cutting people off. And I will try to do it in the most, well, you will maintain your dignity. I won't take that away from you. We're going to begin, though, with Dr. Simon Hatcher.
Okay, good evening. Thank you for coming out such a lovely evening. So, bonjour tout le monde, kia ora. So my name is Simon Hatcher. I'm a psychiatrist. I'm an academic psychiatrist, so I spend part of my time doing research, clinical research, and part of my time doing clinical work. Some of my clinical work is just down the road here at the downtown shelters, and the rest of the time is at the Ottawa Hospital in the medical and surgical wards and the emergency departments. And the reason I'm telling you that is to establish my clinical credibility for what I'm about to tell you. And that is that antidepressants are clearly overprescribed, especially in Canada. This is a league table of the amount of antidepressants consumed in the OECD over 2 years, over 2000 and 2011. And you see that Canada is the third highest user of antidepressants in the OECD. It probably means the third highest user in the world. And compared to the OECD average, compared to some other countries, Canada is clearly way ahead or behind the game. This is clearly antidepressants are overprescribed. It's a fact. You can't argue otherwise. Really, when compared to other places. This is really just restating it, really in a nicer picture, which I borrowed from the claims. This shows you the prevalence of depression amongst Canadians and various other disorders. And remarkably, we take, in Canada, we consume about as many antidepressants as the Americans, which is surprising, but it's true. So, antidepressants are clearly overused. Now, why is that? Is it because depression has been getting more common? That's one explanation. This is two graphs from a study done in 2012 in Canada, and the graph on the left shows you how many people reported that they were depressed in a serial surveys through the National Public Health Survey. So every few years there's a very large survey done in Canada of people's health. And this is the number of people who report they're depressed. And you can see they're two flat lines. It hasn't really changed. On the right, you'll see that the number of people reporting that they are taking antidepressants is doubled over the same time period. This is not because depression is getting more common. The rate of increase in antidepressants is clearly out of keeping with the change in the rates of depression. So in 5 minutes, that's the point I'm making about antidepressants being overprescribed. I'll tell you one argument I'm not making. I'm not making the argument that depression doesn't have a biological basis. Clearly, you're listening to me now, your brain there's chemical reactions going on in your brain. And when people are persistently depressed, presumably there are chemical reactions, there are changes in the brain which coincide with that depression. So I'm not arguing that there is no biological explanation for how we feel, the depression, for people being persistently depressed, for withdrawing from people they love, from isolating themselves, and for thinking thoughts about wanting to die. I'm not making that argument. What I am making the argument for is that our response to that is inadequate. Antidepressants are not an adequate response. I've tried to demonstrate that antidepressant prescriptions are in Canada, especially Canada, they're overprescribed. Are they, and it's something that isn't particular to the UK. So there's been a big, to Canada, there's a big debate in the UK and virtually every other Western country about this particular issue. And it's not, and one of the issues is the rate of increase. It's not just the overprescription, it's a rate of increase. There's almost like a doubling every 10 years of antidepressant use in different countries. The second part of the argument we're putting forward is, are they effective? Well, not very, is the answer. These are figures from a review in the British Medical Journal. And they reported the number of people who needed to be treated over 8 weeks to get one extra person better compared to placebo. And for people with mild depression, which is the majority of people with depression, you've got to give 16 people antidepressants to get one extra person better compared to placebo. They're not that effective. For moderate depression it's 11, and for severe depression it's about 4. Even for people who are severely depressed, you have to treat 4 people with antidepressants to get one extra person better compared to placebo. So they're not that effective. And that's the argument that we're making. Thank you very much.
Thank you, Dr. Hatcher. And I must apologize because I made a bit of an error at the beginning. I really should have read out the complete biographies of our 4 panelists. The reason I didn't do so was because I was concerned about time. But I think your point is well taken, that it establishes your credentials. So if you just will indulge me, I'm just going to read Dr. Blier's biography.
Have we got time?
This doesn't count in my 5 minutes.
So Dr. Pierre Blier is a professor in the departments of psychiatry and cellular and molecular medicine at the University of Ottawa's Faculty of Medicine, and director of the Mood Disorders Research Program at the University of Ottawa's Institute of Mental Health Research, the Royal Ottawa Mental Health Care Centre as well. Dr. Blier has a basic research laboratory investigating mechanisms of action of psychotropic medications. He carries out investigator-initiated clinical studies and treats patients with mood and anxiety disorders in clinic daily. Dr. Blier is the Canada Research Chair in Psychopharmacology and is the recipient of several awards, including the biennial CINP Basic Research Award in 2010. And Dr. Hatcher, I will also be yours in a few minutes. Thank you, Dr. Blier.
Thank you, and I will just add to that. I've been doing research on antidepressants since 1978, even before I entered the medical curriculum. So, you've seen this slide from Simon. No big surprise here. 86 doses per 1,000 people, so that amounts maybe to about 9%. You don't see the figures for Canada going up, but they were certainly going up because the 2000 data were not there. However, it's not because utilization of a medicine is going up that they are being misused. In fact, if you look from the same study, if you look at antihypertensive in Canada, it's high. In all other countries, it's going up. So the treatment of hypertension is going up. Doesn't mean that it's being misused. And similarly, the anti-diabetics have doubled in the same period, and the medications to lower cholesterol have tripled. So my position is that it's not because it's more treated that it's necessarily inadequate. This is a very important point. The other issue, and Dr. Hatcher did mention that, acknowledge that of course we use antidepressants to treat depression, but also they are first-line medication to treat anxiety disorders, like panic disorder, like social phobia, generalized anxiety disorder. So yes, the prevalence of depression is around 4 to 5%. Antidepressant use, 9%. Big discrepancy, but if you start adding the anxiety disorders, then you have to ask yourself the question, are antidepressants actually underprescribed? And it's not just for anxiety disorders. Antidepressants, quote unquote, and I'll come back to that when we have time, they're also used to treat problems in medicine at large. For example, they're widely used to treat or prevent migraine headaches. They're used in chronic pain. I'm sure you've all seen on TV the commercials for Cymbalta, which has an indication for chronic pain. So you see, it's used for a lot of things. So the analogy here is, well, if you're using 81 milligrams of aspirin, are you using an analgesic or are you using an anticoagulant? Depends on the dose. And here it's the same thing. For some of these conditions, we use less, and the antidepressant is actually a misnomer. So that's my statement for the prescription of antidepressants. Personally, I think maybe they are underprescribed. With respect to their effectiveness, there are 4 points I would like to address. First one is the magnitude of the placebo effect, and we have to realize under what conditions antidepressants are used. And the numbers that Dr. Hatcher showed you are for short trials, like 6-week trials. However, depression is not an acute disorder like a sore throat or throat infection. It's a long-term disorder, and it has to be treated over a long period of time, and that's very important. Dr. Hatcher mentioned the severity of depression and suicidal ideation. I'll tell you a big downfall of the way we're actually assessing the efficacy, which is underestimating the effectiveness of the antidepressants. Let me give you some examples. So this is improvement of the severity of depression in a 6-week trial comparing placebo, so a sugar pill, to 3 different doses of effective antidepressant. The first thing you look at that, you say, well, placebo response is huge. So why bother give antidepressants when the difference here, which is still significant, is very important? Well, you have to realize that when a patient is introduced in a clinical trial, they're seen by a psychiatrist, a research assistant, once, sometimes twice a week, and they spend a lot of time. So this has a therapeutic effect, and as well they can call one of the treating physician 24 hours a day, 7 days a week. So that's very comforting. So this placebo effect is not just placebo, it's great tender love and care and research. We treat our patients really well. And the other thing is that in these studies, we cannot include patients who have severe or important suicidal ideation. So if you look at the severity of the mood impairment, it's quite high here. It's at the 4 level out of a maximum of 6. And if you look for suicidal thoughts, it's very low. So we exclude the worst patients, the ones who are the most ill, and then you're asking us to separate them by a very small number needed to treat. I'm sorry, but this is a big downfall, and you have to look at the effectiveness over a long period of time. And this is the results of a long-term study, and this is very important. That's going to be my final point. You have to treat people for a long time. So in this study, patients were treated for 10 weeks, followed by 6 months of maintenance, and were included in this 2-year prolongation. So everybody was well here. And over a 2-year period, when people were switched to a placebo, as you can see here, you have over 70% that actually relapsed within that window. Whereas the people who were maintained on an antidepressant, only about 25% relapsed. So this is very important, Because all the statistics that Dr. Asher told you about people being depressed, well, in long-term treatment, people are on antidepressant and they're not depressed because we have to treat depression for a very, very long time. And this is important. And therefore, the statistics, in my opinion, are really grossly underestimated. It is a very important problem. And I'm sorry if I'm being a bit pushy here, but I will not be a delinquent, and I will stop my argument here.
Thank you very much, Dr. Lee. I'm just going to read the bio for our next debater. Dr. Hazen Gandhi has been a practicing child psychiatrist at the Children's Hospital of Eastern Ontario for the last 19 years. He's presently the Division Chief of Community-Based Psychiatry at CHIO. He's an associate professor in the Department of Psychiatry and head of the Division of Child and Adolescent Psychiatry at the University of Ottawa Faculty of Medicine. He is also the medical director of the Eastern Hub site of the Provincial Telemental Health Service for Children and Youth. Dr. Gandhi's clinical focus has been working with severe mental illness within a broad range of diagnoses, mood disorders, personality disorders, dual diagnosis, abuse and trauma, and psychotic disorders in outpatient, day hospital, consultation liaison, and intensive inpatient services. Dr. Hazen Gandhi.
Thanks very much, Adrian. So I'm going to sort of pigeonhole myself into a particular position within this discussion. One is I'm primarily a clinician. I'm not a researcher, and I'm going to make no attempt whatsoever to go head-to-head with respect to the data. I always enjoy listening to Dr. Blier because his presentations have a surgical precision to them. My other part that I'm going to do is I'm going to pigeonhole myself into a bit of a foxhole, and that allows me to poke a stick at some issues. And I'm hoping if I poke a stick, then there'll be some interesting discussion around it. Yes, there's a lot of data reflecting the notion of an expansive use of antidepressant medications. I'll just add a few figures to this, to the numbers you've seen. So in Australia, from 2000 to 2001, a 95% increase in the rate of prescribing, now representing almost 70% of all psychotropic medications in Australia are antidepressants. In the UK, in 1998, 50 million prescriptions. In 2012, 40 million prescriptions. Interestingly, the increase, almost half of the increase, occurred between 2008 and 2012. In the US, a 400% increase in prescribing of antidepressants since 1998. In a present time, that represents, presently, there's roughly 1 in 10 Americans on an antidepressant medication, and as noted previously, roughly 1 in 9, 1 in 10 Canadians on an antidepressant medication. Certainly, as a child and adolescent psychiatrist, we're also seeing increasing rates of prescribing in children and youth. Now, in terms of effectiveness of antidepressant medications, fortunately, I'm in a little bit of, I can speak again from a child and adolescent perspective, and in some respects, the information about effectiveness is very clear. What we haven't talked about here, and probably we'll have a bit of a discussion about it, is, of course, there's different types of antidepressant medications. Older antidepressants are what we refer to as tricyclic antidepressants. Some of the newer antidepressants are selective serotonin reuptake inhibitors and other variations of that. What we know in the literature for children and youth, and this has been demonstrated through several meta-analyses looking at many clinical trials, randomized controlled trials, is that tricyclic antidepressants absolutely don't work for depression in children and youth. So I can state that very clearly. And fortunately, that's resulted in any recommendations or guidelines with respect to prescribing antidepressants in children and youth. Tricyclic antidepressants are not part of that picture anymore. And that's a good thing. Why is that a good thing? When I started practice, I won't say how long ago, but many years ago, as a consultation liaison psychiatrist, in the course of a year, I was typically called to consult on probably half a dozen kids admitted to the ICU, near death from TCA overdoses. These are potentially fatal drugs and overdose. Unfortunately, with the shift from moving away from the use of tricyclic antidepressant medications, I don't see that anymore, and I'm very, very pleased about that. Now, a little bit of a stick poking, if I may. You're saying, what is this slide? Very quickly, this is someone blindfolded with a bow and arrow. My point here is a couple things. Most prescriptions for antidepressants are not prescribed by psychiatrists, they're prescribed by primary care physicians. What's the average time spent with a patient for primary care physician? Probably less than 15 minutes. And in that 15 minutes, if I'm a patient and I come in and I say, I'm feeling sad, and I lost my appetite, etc., symptoms of depression. By the way, if I present with that picture, there are some studies that would suggest that 81% of the time, patients leave the doctor's office with a prescription for an antidepressant medication. But here's what the physician's doing. Blindfolded, with their bow as their prescription pad and the arrow as an antidepressant, they're going, oh, well, I think it's kind of over here. In those visits, the data would show that many physicians prescribe an antidepressant, but in their notes, they don't even mention that there's a diagnosis of depression, right? So this is a concern in terms of what's the accuracy with which we're diagnosing depression. The rates of prescribing are increasing dramatically. Are all these people appropriate candidates to go on antidepressant medications? I think this is a huge question. Next slide. Thank you. My second point, and I'll stop with this, is when the arrow lands, my point here is that wherever the arrow lands, we are, as clinicians, as researchers, the pharmaceutical industry, we are somewhat complicit in this activity of wherever the arrow lands, what we do, instead of the arrow hitting a target, wherever the arrow lands, we simply paint a target around it. So, gee, if you're feeling a little bit better, oh, that means the antidepressant works. And that's not necessarily the case. And there are huge challenges in terms of our prescribing, in terms of the literature, in terms of the relationships between researchers and clinicians, researchers and the pharmaceutical industry, that I think is part of a broader conversation we have to have. So I'm going to stop there.
The last debater is Dr. Richard Bergeron. He's a physician, psychiatrist, and neuroscientist with the Ottawa Hospital Research Institute. He is also a professor in the Department of Psychiatry and the Department of Cellular and Molecular Medicine at the U of O Faculty of Medicine. His scientific interest is to study the function of the NMDA receptors in the central nervous system. The clinical impacts of Dr. Bergeron's research involve schizophrenia, dementia, stroke, and affective disorders. Dr. Richard Bergeron.
Thank you very much. I don't know why I've been selected the last one to speak. David, I take it a bit personal, maybe I'm not important for you, but anyway. Talking after these three wonderful colleagues and physicians, it's very easy, not too much to say, but what I would like to give you as a take-home message is, first of all, depression is a medical disorder. It's a severe disorder, and the biochemistry of the brain is disturbed. This is clearly shown by many studies done in the last 3-4 decades. If I tell you that you have a disease and 15% of the chance you are going to die of this disease by a suicide because you're fed up about life, I think that's a terrible disease. Who can be affected by depression? Children, teenagers, adult people. In the last few years, I worked more and more with elderly patients because we are interested in Alzheimer's. And you know, the suicide rate is much higher in the elderly people compared to the teenager. even though we speak on the newspaper and on TV, teenager committing suicide, it's terrible, it is indeed terrible, but many elderly patients will stop their medication, will stop eating, sometimes will kill themselves with a knife, with a gun. We have not the best treatment that we hope for treating depression. The antidepressant drugs are good, efficient. We all would like to have drugs that are more efficient, that act more rapidly. We would like antidepressants that are not giving any side effect. And of course, we would like antidepressants that are much more convincing in terms of effectiveness compared to placebo. But you know, to respond to a placebo, it's not because you are nuts psychologically. Placebo can also decrease the size of a tumor, can help many other medical disorders other than depression. As mentioned by Dr. Villiers and I, we did many times clinical trial, and when a patient comes on a clinical trial for depression, these patients are spoiled because they don't have to wait 3 hours in the waiting room. There is a nurse, the secretary is nice, they welcome them, we take care of them, we fill out the paperwork. Of course, there is a psychological impact of being so close to the patient. And this is why probably we have a huge placebo effect in clinical trial. So in other words, I believe the antidepressant drug is much better than what the study showed us in the last 25 years. If one day I have a depression, that could happen to any of us, I will certainly talk about that with my family doctor. And because I know a little bit about depression, probably will be easier for me to go to see the doctor and say, you know, doctor, I think I'm depressed because I have this and this and this and this. But for many people, going to see a doctor and talking about depression, that life is not worth anymore, I have nothing that excites me, I'm lazy, my wife believes I'm lazy, I don't do anything, she pushed me to take a shower or a bath because I don't want to do anything, I don't care about anything. Well, that's difficult to admit. But depression is probably not treated as it should be. Many people in Ottawa, Canada, North America are suffering with depression and they don't see any health professional. And that's why I believe that the antidepressant drugs that are not perfect are safe, are efficient, and should be more prescribed to people who are suffering with depression. Again, my take-home message is depression is a medical disorder. We should not feel ashamed suffering of depression. And with all respect I have for my colleague, I think the good side of the discussion tonight is on this side. That's something personal. Thank you.
We're entering the freestyle round, but I'm just very quickly going to read the biography for Dr. Simon Hatcher. Dr. Hatcher is Vice Chair of Research at the Department of Psychiatry, Faculty of Medicine here at the University of Ottawa. He's been the principal investigator in several large trials of non-pharmacological interventions in people who present to hospital with intentional self-harm. Dr. Hatcher is currently based clinically at the Royal, providing services in downtown Ottawa homeless shelters and working in the Liaison Psychiatry Service at the Ottawa Hospital General Campus. His main research interests include suicide, self-harm, psychotherapies, psychiatry in a general hospital setting, and e-therapies. And Dr. Hatcher, I'm going to ask you to respond to what Dr. Bergeron just said. I think you kind of laid down the gauntlet.
No, I'm actually going to respond to what Pierre said. Overdiagnosis and overtreatment is a major problem in modern medicine. It's not something that is just peculiar to psychiatry. You may or may not know there is a campaign started by the British Medical Journal and the Journal of the American Medical Association and several other academic institutions to address this. And there was actually a conference in Harvard a few months ago, which was specifically around the theme of too much medicine. And you know what? The two poster childs for overprescribing and overtreatment were exactly the ones you mentioned: antihypertensives and diabetic drugs. Yeah, those are the two big examples outside psychiatry of where there's an explicit overdiagnosis and overtreatment.
Why is that a problem? Why is overtreatment and overdiagnosis a problem?
Because people get harmed by too much medicine, and they get labelled and treated and feel behave as sick when perhaps they're not.
So is the harm in not being prescribed these drugs greater than the harm in being prescribed the drugs?
Well, that's always the judgment that a clinician has to make.
What do you think?
What I think is that you have to, it's very careful consideration, and in a majority of times, with the strength of evidence about the effectiveness of antidepressants, I think you have to sit back and wait, and often you have to trust people to find their own solutions whilst being perhaps held in a therapeutic relationship.
What does the evidence say?
The evidence says actually that's a reasonably good way to go, actually, especially in primary care, which is where most mental health care happens, is that waiting and seeing is a tremendously powerful intervention in primary care for everything, not just depression.
Dr. Lee, a pretty powerful argument. Would you not agree?
No, not very strong. Because if we take antihypertensive and antidiabetics, I mean, high blood pressure can be measured very easily, and you have to measure it, of course, in the right condition, just like when you assess depression. But when blood pressure is high, it erodes the cardiovascular system and has a very negative impact on the fine vasculature of the brain, of the retina, of the kidneys, and so on. And the problem is that it's a silent killer. Of course, you don't get side effects until you start getting treated, so it's very important. Same thing goes for antidiabetics. I mean, when your blood sugar is high, it's very corrosive to the blood vessels. So you have to treat these people because there are long-term consequences. Just thinking that you overtreat people, shutting your eyes on the problem is not going to solve it.
So are you saying there's no such thing as overtreatment?
There can be overtreatment. Some people are on antidepressant and should not be on antidepressant.
So you agree with him?
No, not at all. Because what's important is that not everything that cries is depressed, and you have to take the time to assess people.
So what constitutes depression? What does it mean to be depressed?
Being depressed is actually showing these signs and symptoms, having either low mood, lack of motivation with accessory problems with your sleep, with your appetite, with your psychomotor agitation or retardation. And these symptoms have to be there for a certain period of time, and the crucial part is that they have to interfere with your functioning, whether it's social, professional, and so on. So like Dr. Bergeron said, it is a true medical disorder, and what people have to accept is that the brain is incredibly complex. We probably have over several hundred different types of cells in the brain, and people don't accept that some of them can go array, but for the stomach, we only have one type of cell, but everybody agrees that we can treat a stomach condition.
But surely you don't believe that the answer always lies with medication?
Of course not, and I did not show my last slide when the TAD study in the adolescents from 12 to 17, and yes, psychotherapy was effective, but actually the medication was more effective than the psychotherapy in this study of 340 adolescents, and the combination was, of course, better. So it's not always the answer, but it's important. We have a medical disorder, we have to recognize it, and we have to treat it aggressively.
So if it's not always the answer, then sometimes it isn't the answer.
Oh, absolutely. Some people.
So you do agree with Dr. Adrian?
No, I don't agree with it, because medication is not the solution for everybody, but psychotherapy is not the solution also. Healthy lifestyle is, of course, very, very important. You don't put crappy fuel in a Ferrari, and the Ferrari is the human body. So you have to feed the body well, you have to exercise, you have to follow a good lifestyle. And of course, sometimes medication is essential.
Thank you. Dr. Gandhi, do you have a rejoinders now?
Oh, boy. So, just a couple of themes that I'll highlight. I'll pick up on the TAD study, the treatment of adolescent depression study. Yeah, you're right. One of the outcomes of that study was the notion that a combination of antidepressant medication and psychotherapy had the best outcome. But in point of fact, that study was criticized because the design of the study resulted in some arms of the study not being blinded while other sides of the study were. And the result of that was a bias towards a kind of an over-reporting of the effectiveness of medication. So, and this phenomena, this notion of study design and trials, is a huge issue. And I don't want to talk about it a whole lot because I'm going to get into an area that I don't have a lot of expertise in, and I'm sure Dr. Lee could talk further about it. I'm going to pick up on the other point you said, coming back to the symptoms of depression: low mood, loss of appetite, loss of interest in things, can't focus and concentrate, etc. Right? Those would constitute the symptoms of depression. If my mother dies, I'm going to feel the same way. Is that depression? That's grief. That's a universal human experience. And one of the challenges is, in this discussion is, how do we classify mood disorders? How do we classify mental illness? This year, an updated classification system, the DSM, was 4. Now the DSM-5 was released. And one of the interesting things in DSM-5 was that they made some changes with respect to the section of mood and anxiety disorders, and now include grief as potentially a depression that should be treated with antidepressant medications. And interestingly, the physicians who made that recommendation were physicians who had pretty clear ties to the pharmacological industry, right? So these are difficult challenges and are part of a challenging set of dynamics that I think contribute to the numbers that we've seen with respect to the prescribing of antidepressant medication and who we're prescribing these medications to.
But if a person's grief becomes protracted and lasts years and years and years, can a case not be made that at some point there does need to be some kind of medical intervention?
That may be the case, but where do you draw the line?
Well, where do you draw the line?
I'm a physician that works in the tertiary care facility. The majority of the kids that I see are kids certainly on at least the moderate and mostly on the severe range of depression. So for me, a cutoff is if their symptoms are at a point where they may be placing themselves at some risk, if they're developing suicidal ideation, if they're thinking about acting on that suicidal ideation, if they have significant neurovegetative symptoms, if they're not functioning, then yes, I agree, there may need to be some intervention. But if I go to my primary care physician and I say, look, I don't feel well, blah, 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 again, in 81% of the cases, I'll come up with an antidepressant.
But in that particular instance, that particular
even though
example,
the reason for that might have been because, yeah, my cat died.
you just gave that example. What do you think Dr. Bergeron would say in that particular case? How do you think he, like, given what he said so far, how do you think he would address that particular example?
I can't read his mind.
No, but what would you presume? Given the position that he's representing, how would he address that particular situation? In your estimation?
Again, certainly depression can be life-threatening. Certainly depression can be debilitating, and I'm with the rest of the panel that depression is absolutely a medical illness. But not all depression needs to be treated with antidepressant medication. There are a whole range of other types of intervention. Simple things. We know that exercise in clinical studies can be as effective as antidepressants for mild and moderate depression, as an example. And frankly, the research is telling us that for mild and moderate depression, not a lot of people benefit a great deal from antidepressant medication. But when they go to the primary care physician, that's what they're most likely to get. Why? I think a reason is primary care physicians are pressured to see a lot of patients. They also feel a responsibility to do something, and the quickest, easiest thing to do is prescribe a medication. Sometimes it works, but a problem is that they go away with a prescription, and they don't come back to their family physician. they keep getting an antidepressant medication for weeks or for months, sometimes for years, and there's no follow-up, there's no reassessment to say, is your depression better? You need to be on these medications at some time. I don't disagree with you that sometimes depression needs to be treated for a long time, but consider this. We now have a generation of young people who would have started an antidepressant when they're 12, now they're 22 or 23. They spent most of their lives on antidepressant medication. What is that? What are the implications of that?
Dr. Bergeron, there's a lot of attention focused on serotonin. To what extent is the reduction of serotonin cause for depression?
Clearly, serotonin is one of the chemicals in the brain that is known to control mood in people. There are many other neurotransmitters in the brain. And the brain is a huge computer, extremely complex. And we know now that if we study just one transmitter alone, we are missing the most important of the entire network. They are all connected together, these neurons. Just for example, we have a part of the brain that is called the hippocampus, like the seahorse, you know, because the shape of the brain is like a seahorse. And just one neuron of that brain area, just one, make probably 25, 30,000 connections with the neighbor neuron. So it is extremely complex, and of course, the serotonin is important to control mood, but we all know, including Dr. Billet, who worked on the serotonin for many years, that other neurotransmitters are also involved with the chemistry of the brain and can control mood. But I would like to come back on one important point for grief. Okay, I would just say something a little bit personal. Almost 10 years ago, I had a brother. He was at that time 45, and he passed away of a heart attack without any sign of problem. That was a shock. I mean, it's the first time in my life that I felt someone close pass away. And of course, the worst was for my mother. And my mother told me that there is no more pain that you can feel in life than a mother losing a child. And my mother was a very enthusiastic person, always in a good mood. When that very sad event happened, I can say that it was really a shock for my mother. Of course she was sad, she cried, probably she had many sleeping problems for many weeks. But you know, I don't think she went in a major depression because she was with family members, friends, and she knew that was unfortunately part of life. Death can happen to any of us. She was able to function, she was able to go out, to keep the social networking with the friend, the family. But talking about the brother, 5, 6, 7 years after that, she was still crying because it was a sad moment. But she was not in a major depression. She didn't use antidepressant because she was functional. That's why you have to draw a line. We don't give antidepressant to people who cry. Could, but if you give antidepressant to people who are crying, people who feel sad, sometimes I feel sad when my grand is turned down by the committee. Major depression for 48 hours. After that, I recover.
Dr. Bergeron, aren't you making their argument for them? In the sense that what you're suggesting is that your mother, thankfully, belonged to a very strong community. She belonged. Yeah. She had a family around her. She wasn't alienated from her community, and as a result of that, she was able to manage her grief. And perhaps that's what Dr. Hatcher and also Dr. Nandi are suggesting, that medication isn't necessarily always the answer. Maybe we need to strengthen those bonds.
And as mentioned, I think by Dr. Billet also clearly, antidepressants are very useful, and it's a part of the treatment, very, very important, but you don't treat depression only with antidepressant. You need some psychotherapy, you need to advise the patient to have good habits. I believe physical exercise is also a good antidepressant, but I will never give, for a severe depression, a patient coming to my office, I will never say, well, just do physical exercise and you will feel better. it will be part of my treatment plan to eat better, to have good habits, avoiding abusing alcohol or drugs. Yes, physical exercise will be part of my suggestion, the overall treatment plan. But I believe that when you work with the chemistry of a very complex organ like the brain, the antidepressants that we have, even they are not perfect, they are doing something to the chemistry, they establish the chemistry of the brain. And unfortunately for some people, they may need antidepressants for their life. Maybe not everyone, but remember, depression is a chronic, recurrent disorder, and if you don't treat well the first couple of episodes, it will be recurrent and you will have this severe disorder maybe for the rest of your life.
I'm starting to sense a real problem in this debate, and that it's that the four of you are too reasonable. Perhaps. Dr. Gandy.
Can I do some more stick poking?
Please.
Dr. Bergeron has referred to the chemistry in the brain, right? All right. All serotonergic antidepressant medications, all of the research, all the work, all the outcome, all the prescribing is predicated on the notion that these serotonergic agents affect serotonin in the brain. Right? That's pretty well said. Okay, so here's a huge problem that we have. If I have hypertension and I go to my doctor, how does my doctor know that I have hypertension? He takes my blood pressure. And he takes my blood pressure and he sees my blood pressure is high. And then he prescribes an agent, maybe inappropriately, that's going to act on receptors and on systems in the body, and the result of that is my blood pressure is going to come down. So in 2 weeks' time, or whenever I come back to see him, he measures my blood pressure, and it's changed. He also knows, based on a lot of data, what normal blood pressure is. Now, again, I'm stick poking here. So if serotonergic drugs affect serotonin levels in the brain, what are normal serotonin levels in the brain? Do we know that? Do we actually know that? Can we? And as a clinician in my office, do I have any way of measuring that to determine is it too high, is it too low? No, the only way I can measure that is indirectly through my patient's description of their subjective experience. And some patients are really good at describing it, and some patients are not so good at it. And I have patients who can't describe it at all. They may be non-verbal. And their parents or the caregivers come in and say, boy, there's changes in their behavior, maybe they're depressed. And I can't get any information about what's actually happening in the brain. And so I think this is a huge problem in terms of our ability to really understand what's happening in the brain neurochemically.
Well, I think Dr. Bergeron and I made the case that the brain is incredibly complex, and you're not trying to reduce everything to serotonin. There's not just one neurotransmitter.
But these drugs only work on one serotonin. I mean,
That's not true.
Some of them work on more than one, correct? But many of them only work on one.
No, we have, just like in the treatment of hypertension, and this is, thank you, a perfect example. Your family practitioner will measure your blood pressure. He will know that it's high. He gives you a medication. How does he choose that medication? Is it a beta blocker, an alpha antagonist, an ACE inhibitor? He doesn't know. And it's not true, but when you come back in 2 weeks, if your blood pressure is going to be down, there's an incredible amount of resistance. And we cannot pick treatments, whether it's for hypertension or for the treatment of depression, with clear vision, 100%, and certainty with what's going to work, what's not going to work. Hypertension and depression are very treatment-resistant conditions. That's very important. And just to come back to your point as well, and Dr. Bergeron said, antidepressants, when they are given, they have to be given for a sufficient period of time. And sometimes we hear in the media, antidepressants are addictive. I only wish they were, because patients would take them for an adequate period of time and would not stop prematurely. It's the same thing as taking antibiotics. You take antibiotics, you have a fever, it has to drop in 48 hours. You have to take it for 10 days because it can come back with a vengeance. It's the same thing for the antidepressants, but there you're not talking about days, you're talking about months and sometimes years, because it can come back and hit you with a vengeance.
You're clearly a major advocate for people even being addicted to antidepressants. How do you explain the fact, though, that antidepressants don't seem to be that successful with young people, and in fact it seems to make their depression worse?
That's a very good question. I don't think we can answer, and certainly using tricyclics in adolescence is really not the way to go. They can be very useful in older adults. And there are probably more factors that are at play in the developing brain of these young people. For example, we know our frontal cortex does not fully mature until we're about age 25. So there are plasticity issues that may be at play here.
Dr. Gandhi, quickly, and then Dr. Hatcher.
Sure. Important to note that children are not small adults, right? And so their brain is a different size, their livers are a different size, their capacity to absorb drugs is different, the way they metabolize drugs is different. And part of the challenge in my field as a child psychiatrist is most of the research and the recommendations on how to use these medications comes from adult research that's extrapolated down to children and adolescents. And that extrapolation doesn't work for them.
Dr. Hatcher?
I'd like to address one point that Dr. Pierre made in his talk, which is that one of the reasons why you see so many antidepressants prescribed is because there's so many other things antidepressants can treat. You can do anxiety, you do pain, and a whole list of other things. This is classic indication creep. The medications which are running out of steam and going off patent. And if you think antidepressants don't work for depression, you should see the figures for anxiety and pain. They're not that great. If you go to a pain clinic, one of the first things the anaesthetist will give you is a tricyclic antidepressant. But it doesn't work that well, quite frankly, for chronic pain. There's some evidence that it works a little bit, but not that well.
Probably mostly placebo.
Maybe so. And you can see it. You can see it now for these antipsychotics, which are beginning to come on patent. Seroquel. Everybody, their dog takes Seroquel in Ottawa. It's like Smarties. I could not believe it when I first came here. And it's classically, so for antipsychotics, it's now being marketed for difficult behaviour in older people, for sleep, and a variety of other indications beyond treating psychotic symptoms. And it's classic indication creep in medication which is getting past its use-by date. So that's one point I wanted to make. The second thing was to open up another line of argument. I moved here from New Zealand 2 years ago, and I still remember the first patient I saw, which illustrated a number of the strengths and difficulties in the Canadian health system. And she was a woman who had to drive an hour and a half to come and see me. That's crazy. We got telemedicine, we were seen on telemedicine, but we didn't use it. Why? Who knows? But that's one of the problems. And I saw her, and she'd been waiting months to see me, but a week before had seen another psychiatrist, which is, again, an issue. When I saw her, she was taking 4 antidepressants and 3 different antipsychotics, and at least 1 benzodiazepine. The point I'm trying to make here is the issue of polypharmacy, taking more than 1 antidepressant at a time. If they're so bloody good, why do you have to take so many antidepressants if they don't work? And it's a particular, I suspect that's one of the reasons why Canada has such a high rate of prescription of antidepressants, is that part of the culture, part of the North American culture I suspect, is polypharmacy, is prescribing more than 1 antidepressant. I've never seen it to such an extent. I've worked in New Zealand for 20 years, been trained in the UK, I've never seen it like I have seen it here. So polypharmacy is both a problem and a sign, I suspect, that antidepressants aren't all they're cracked up to be.
One antidepressant for 1 episode of depression, I would say that's the rule that most physicians will follow. As psychiatrists, we did 5 years training to treat more severe cases. And to come come back to the point of Dr. Hatcher. Yeah, there are polypharmacy in psychiatry for depression because there are some type of depression that are very severe, complex. And again, there is not only one chemical in the brain, many of them. And for the last 10 years, I have to say my colleague Dr. Vier is pioneering that field with his research to combine different types of antidepressants with different mechanisms of action to have a booster effect, make these people feeling better, is not only, oh, it's necessary. And we want to use antidepressants that will act everywhere in the brain, but then we'll get more side effects. So that's why the antidepressant that we use is like the knife for the surgeon. With this one, we're going to do this, and acting the serotonin, you may affect this neurotransmitter also, but if I use another one, I will make this neurotransmitter better, and that will give more energy to my patient who have a better attention. So it's very complex. So that's why sometimes we use polypharmacy. But this is not the rule, and this is not what we hope also.
But isn't this a sign? I think Dr. Hatcher was quite emphatic in making this point. He's suggesting that if these antidepressants were in fact, the panacea to the problem of the patient, why are we piling antidepressant on top of antidepressant on top? And clearly, it's a failure.
Well, if you have high blood pressure, there are 3 subtypes of medication, 3 categories, right? And to suffer of high blood pressure, even to suffer of cancer, probably there are many subtypes of cancer that are very similar. Okay, if I have, prostate cancer, it could be the same prostate cancer than 10 people in my neighborhood. But there is not one depression that is similar to the other one, because as human beings, we are complex, and also because the brain is complex. So you cannot say, well, after my sister was suffering of depression, and she was on Zoloft, and she felt good, so I think I should get Zoloft. That's not exactly what it should always happen. However, it could be, but your sister may be well with Zoloft, and you may be treated with another type of antidepressant. Maybe in your case, you may need 2 antidepressants. That we don't do. But anyway, to close this, polypharmacy is not something we wish, but that's something that is sometimes necessary. And maybe another point I would like to make is, again, my hippocampus. I love it so much, my hippocampus. And as my colleague Dano, a few years ago, I think 10 years ago, some scientists, they selected depressed patients, and they did an MRI. MRI is a kind of X-ray that you do of your brain in 3D to have a very nice resolution of your different brain area. And in that case, they selected the hippocampus. So if you take people about the same age, and you take people with the same background, same education, that are not depressed and depressed, the brain area called hippocampus is smaller than depressed patient. But what is very exciting, if you treat the patient with antidepressant or psychotherapy, you normalize the size of the hippocampus. That's very exciting, very convincing also to say, well, depression affects the chemistry of the brain, can affect the anatomy, the structure of the brain. And if you treat these people, you make these people feeling normal, you can reestablish the chemistry of the brain. So that's why if you have a depression, you need to be treated. Depression is part of the treatment, psychotherapy is part of the treatment, probably to combine both, and to have good habits in your life is absolutely crucial.
Very quickly, Dr. Bergeron, do you stand behind your comrade here, who seems to be very gung-ho about Canadians perhaps taking even more antidepressants than they're currently taking? Do you also agree with that? Do you concur with that?
I agree that there are people on antidepressant that it's questionable. And maybe some physicians, including some psychiatrists, including me, maybe as well, it's looks depressed, but yes, okay, let's get this because it's not going to hurt you. Maybe sometimes we take a shortcut, maybe. But I believe that many people are suffering depression and not treated, and that's the worst drama that exists in the medical field and in our community.
Okay, thank you. We have about 5 minutes left in this freestyle session, and then we're going to go to the audience. Okay. Dr. Mandy?
So there's so many facets to this story, the story of overprescribing. I want to just add a couple of other interesting facets. One is the notion of the relationship with pharmaceutical companies. An interesting parallel is as rates of prescribing have increased dramatically, the rates of a particular strategy used by pharmaceutical companies has also increased dramatically. Rates of prescribing have gone up. And this strategy is called direct-to-consumer advertising, right? Can I give you an example of direct-to-consumer advertising? Okay, it's a little bit of a story, bear with me. The Reverend on Sunday morning is thinking about his sermon for the day, and he decides he's going to go downstairs and check in with the Sunday school class to see if they have some understanding of what he's going to talk about. So he goes down to the Sunday school class, and he interrupts the class and he says, "Okay, children, today I'm going to talk about the resurrection. Is there anybody in the audience, anybody here who can tell me about the resurrection?" And a lot of bewildered looks on the faces of kids. And finally, the little boy sticks up his hand. And the Reverend says, "Ah, Johnny, excellent. Can you tell us what you know about the resurrection?" And Johnny pauses for a minute and he says, "Well, the only thing I know is if you have a resurrection for more than 4 hours, you should probably see a doctor." Johnny watches the Golf Channel. But this, I'm making fun of it. But this is an interesting issue. It's an interesting issue because this form, by the way, gentlemen, you signed this form. This is our confidential disclosure of conflict of interest form, right? What is this? This is a document that lays out very specifically what our relationship is going to be with the pharmaceutical industry. And it's supposed to be an arm's length relationship so as to reduce the chance of bias when we prescribe medications. And interestingly, the pharmaceutical company's response to that is direct-to-consumer advertising. Because now they don't have to talk to physicians about their medications. They can talk directly to patients. What's the result of that is? Patients come into their doctors and they say, "I heard about this medication, Zoloft. I'd like to go on Zoloft for my depression." And interestingly, patients who come in and ask for a medication are 17 times more likely to receive that medication than those who come in and just describe their symptoms and don't identify directly what they want. So I think it's those kinds of dynamics that also contribute to this difficult challenge of overprescribing depression medications.
You're chomping at the bit, Dr. Glier.
Yes, talking about, don't get me wrong about the gung-ho position. When I assess a depressed patient in our clinic, for example, I'll spend at least 45 minutes with that person and adding on top of that a lot of information. So I fully agree, you can't diagnose a depression in 8 or 10 or 12 minutes. And that may be a little bit the problem of our healthcare system. Now, to come back with some of the claims that Dr. Atcher made with chronic pain, for example, well, if you study neuroanatomy a little bit more carefully, some of these serotonin norepinephrine projections going to the brain also go down in the spinal cord and can control actually the control of the perception of pain. And this is why some of these antidepressants, which is a misnomer, can be effective, and it's only our inadequacy to call the drugs actually what they are that is the problem. And I'm part of an international nomenclature committee, and we're renaming our 138 psychotropic medications by their mechanism of action, not for their initial approval on the market. And then finally, I'd like to conclude with that polypharmacy issue. Let me relate to you. When you had your asthma attack, they didn't give you a single medication. They probably gave you 2, probably 3. First manifestation of asthma, you'll get 2 types of medications, if not 3. It's the same thing for high blood pressure. So we have to actually realize that even some simple disorders like asthma or hypertension sometimes needs multiple targets. So I would advocate that it's not blind polypharmacy. When a psychiatric patient actually receives a combination of medication, it's called a drug cocktail. Well, that makes me jump out of my skin. It's not a drug cocktail. It's actually what I call rational side-directed pharmacotherapy. We're shooting at different things to get the proper clinical outcome.
Dr. Hatcher, does that satisfy your concerns?
Conflict of interest form. I have no conflict of interest. This is answering your question. I've never been funded by drug companies to do my research, or I don't think I've even been taken to lunch by a drug company. I'd be interested to know what the other panelists have put on their conflict of interest forms. But so that's partly my response to that. I'm actually not going to take up any more time, because I can see people in the audience are champing at the bit. So maybe we should open this up.
Well, I would like you to respond directly to Dr. Lee. Oh, because he's saying that this notion of he's saying that you're making this fallacious charge about the so-called drug cocktail, that there's no basis for it.
Oh, the drug cocktail. Yes, pharmacologists love that, don't they? There's no evidence from trials that, there's very little evidence from clinical trials that either increasing the dose of antidepressants or adding in extra antidepressants actually makes them more effective.
But it does increase the chance of side effects.
It does increase the chance of side effects, yes.
You should read the literature a little bit more.
So now things are settling down.
Actually, if only I had time to read the literature, but I'm on the on-call rota. I don't know if you two do on-call.
I think we're at the end of the bare knuckles round, and we're now ready for you, the audience, to participate. I would ask, though, that you keep your questions as concise as possible, please. Go ahead. I think we need a microphone. If you can just go to the microphone so that everyone can hear.
Hi, I'd like to ask Dr. Bergeron and the question that there is no impact on brain from psychological factors, being psychological factors don't affect brain. So?
What I just mentioned about the MRI study, antidepressant will normalize the size of the hippocampus, psychotherapy also.
Yes, psychotherapy is so essential. Sometimes psychotherapy itself can help.
Yeah, by itself also. Yeah.
Itself.
Yeah.
And many a time I have been.
So if a patient is coming and says that I don't want to take antidepressant, I will always respect that. However, you have to go in psychotherapy.
Yes, and I agree with you that there are certain, as he said, Dr. N, that there are certain vegetative symptoms and there is a severity of depression. At that point, you need medication. But basically, for the personality conflicts, for grief,
psychotherapy,
for the active depression, these are all just psychotherapy.
Yeah, but psychotherapy by itself can be very, very...
It's not only just the health factor, how you exercise, but I think the object relationship, the traumas, and all those factors. Those are the things most important.
Thank you, ma'am.
Absolutely.
Thank you.
So I'm a family physician, one of those people that see people in 8 to 10 minutes. One of the things that I have that you don't have is continuity of care. So I may know these people over a period of time. The other thing is I never treat hypertension on the first visit unless it's sky high. We bring people back over time and make sure that it's not one reading. We don't treat readings, we treat patients. And finally, when it comes to grief, and it comes to, grief is exogenous, it comes from outside. But when a person comes into me and says, my life is perfect, I have no reason to feel this way, and yet I'm not functioning. That to me is depression. So I think we have to be respectful of each other. We do have a lot of people taking medication. When we look at number needed to treat, you can attack the cholesterol medications. Those would really have a very disgraceful number needed to treat. And the area I would attack is ADHD. That's an area where we're asked all the time to treat active little kids in classrooms so that they'll be calm. But I would say that we have to be respectful of the job that we do, because in fact the family doctors probably are the major prescribers of antidepressants.
Can I ask you a question as a family physician? Because
Yeah.
clearly you have a very, very intense, very, very heavy workload. And I'm wondering if you ever worry that you don't have enough time to properly diagnose.
So it depends on the family doctor,
Or
and I
make a
will not
diagnosis.
defend colleagues who don't do this properly. I do think that we have, just like in every profession, we have people who are better trained or treat people better than we have other people. But if I have a person who's suicidal in my office, the rest of the people in the waiting room wait. So we take the time we need with the patients that we have. You know, it is a disaster in a busy clinic to have somebody suicidal walk into, because it ruins your clinic.
So what would have to
But-
change to make your job easier? Because I think that there was just a concern
Well,
that perhaps
one of the
family
things
physicians
I
don't
think-
have all the information that they require.
Yeah, I think that personally, one of the things that really works is continuity of care and getting to know your patients over time. And that's one of our strengths. We know our patients over time. One of our problems, of course, is when we go to refer to the mental health care system, there's long time to delay. One of my colleagues is using e-consult now, so we can get the information in a timely way. So it isn't a 6 months wait to get help from our colleagues. We need our psychiatric colleagues to help us, but we need them in a timely fashion. And that's one of the things when Simon was talking about using telehealth, and there are lots of things we could do better in the system to work together to improve the treatment of our patients.
Thank you.
But I think telling us that we're doing a bad job because we don't spend a long time is probably a misconception.
Dr. Gandy and Dr. Hatch, do you want to respond to that?
My first response would be, please keep up the terrific work. And my comment is more around the pressure that family physicians, and before I went into psychiatry, you know, I worked in a walk-in clinic, and a 12-hour day I'd see 120 patients. I mean, the pressure to see patients is enormous. And the expectations of patients, you know, when they come in for something to be done is enormous. And so, you know, the pressure to make a difference, to have an impact is huge. I'd certainly agree that we need to do a much better job collaborating with family physicians and primary care physicians, because you're right, they do most of the care, they do most of the identification, and we don't do a great job of supporting their work.
Dr. Hatch?
I agree entirely. Most mental health care happens outside psychiatrist's offices, mainly in primary care. Good on you.
But when Dr. Gandy says we don't do enough, so what aren't psychiatrists doing that they should be doing?
That's another debate. But surely,
But I mean, to assist
three
family
things.
physicians.
There are three things. We need to work differently as psychiatrists, so we're not seeing necessarily straightforward cases of people who are depressed. We should be seeing the more complex, difficult cases and working in teams. Secondly, we should be creating new roles in the health system so that there's more flexibility of response. Third, we should be using technology more.
Thank you. Please.
I can see that when a drug company wants to prove a drug is effective, you want to compare it to a placebo, which is comparing to doing nothing. But when we know that there are other effective therapies, such as nutrition and meditation, why are we not seeing more research that compares the drugs to these alternatives?
Dr. Boulier?
Yes, it's important. First of all, when the medication is approved, it has to go in a placebo-controlled study, and you cannot compare necessarily just with something else, because then you could end up recommending the medication to a lot of people when it is actually not effective. But that's only the first step. The other steps is actually to compare it to active controls. And although there are some flaws in some designs, there are actually controls that are done with other modalities of treatment. The study in adolescents was an example. So there's a lot more research that meets the eye. It's not just the placebo. That's only one way of looking at medication. After a medication has went through some steps, after that, of course, there are other comparators.
Hi, thanks very much for those comments. So I have a case scenario to present that from personal experience, and just wondering if both sides could comment on how they would act if they were the psychiatrist that this patient was seeing. So a government-assisted refugee comes to Ottawa, and he's suffering from severe PTSD and depression. None of his family is here. He barely speaks English. It's winter. He has nothing going for him. He can't even navigate the grocery stores. And he's going to see a psychiatrist. In this case, should she be prescribing antidepressants, given that she's also telling him that he should be talking to a psychologist, he should be eating better, he should be exercising, but he has a lot of barriers to those. Given that she is telling him to do those things, should she be prescribing antidepressants at this point?
Dr. Bergeron?
Thank you. I will refer the patient to the Royal Hospital.
Patients at the Royal Hospital.
Oh.
She is at the Royal Auto.
First of all, PTSD is a very severe disorder, very, very severe. We don't know what's going on with these poor refugees or veterans coming back from war or victim of abuse, any kind of abuse. I would say when I was in postdoc in US, they have what they call a VA hospital, Veteran Administration Hospital, and most people from coming back from war were going to this hospital, and I saw a lot of PTSD. I would say 99% of them were on antidepressant with other form of treatment, psychotherapy, but yeah, they were almost all on antidepressant. We know few studies that have shown some result, some negative result. Probably we don't have the appropriate psychological drug on the market to treat these people, but yes, probably this patient will be or should be on antidepressant.
Thanks for that. And just before the other side speaks, so if antidepressants are started but not working, and the doctor is just giving additional antidepressants or increasing the dose, should we be stopping them? Is it clear that the problem can't be fixed by antidepressants?
Can I take that question? Because actually this has been looked recently in some studies. So the dogma in the field is that if somebody has zero response, you should switch, you should go to something else. And if there's a bit of response, there should be something added. Well, it doesn't really matter if there's no response, and that's been looked at with augmentation studies, because it doesn't mean that when you give an antidepressant and you don't have a clinical response that you did not do anything in the brain. So you should continue that medication and use another mechanism. And that's the basic principle of potentiation in medicine, where 1 + 1 can be equal to 4. And this applies, for example, in general medicine with antihypertensive or hypoglycemics. So it's important to combine medication, because this is a very severe disorder. Going back to this again, and when somebody has AIDS, HIV, what do? They treat them with tritherapy, and that's the standard. So it's dependent on the severity of the disorder and the condition. You have to treat, not maybe aggressively is the word, but more vigorously.
Dr. Yanni, just was, and then Dr. Hatcher.
The challenge here is, treating this patient is a bit like trying to teach them to swim while they're drowning in the pool. This person is drowning in the pool. I think before we start thinking about treatment and therapy, you got to start to address some of the other issues. You got to figure out how can this person be connected to people, right? Find a translator, find other people who can speak this person's language, find ways of connecting this person to other people, deal with issues of housing, help them with figuring out how to take the bus, how to get around. You have to do all of that stuff before this patient's really ready for, for any kind of therapy or treatment. Would I prescribe an antidepressant medication? I think it's a bit of a drop in the bucket until a lot of these other issues are somehow in place so that this person has the infrastructure and the social support just to navigate through a day, right? So I think the issue of treatment has to come after this person's been able to get out of the pool instead of drowning.
Dr. Hatcher.
It sounds like several people I see down in the shelters, actually. And I think it's the wrong question. Because one of the things that's useful for seeing people down in the shelters is to think about that environment as a place where people who've been traumatized end up. And what you're trying to deliver is trauma-informed care. And often one of the first things you need to do is actually have a conversation around having a conversation. So often when people have been traumatized, it's been by people in authority like me. And it's quite scary to come and talk to people like me, because what people have learned is that when they get close to people, they get hurt. And I think that is one of the first steps we need to take, is to pay a lot of attention to engagement, and then do a lot of the stuff that Hazen talked about, which is around some of the practical supports and addressing connectivity, connections to people. And antidepressants, yeah, maybe, but that's not. That's down the track. It's about giving meaning and understanding to their experiences and addressing the issues of trauma and how that affects our ability to help.
So what would have been the right question?
How do you provide trauma-informed care for people who've been traumatized?
Thank you. Okay, so just really want to thank you for all of this tonight. You separated situational or circumstantial depression from biochemical depression. I want to address biochemical, and I want to really talk about, the fact that a primary care physician may not have the resources or fails to diagnose, and you spend years and years undiagnosed, misdiagnosed, trying to find a psychiatrist who's the right fit, and that's a matter of, that can be a total crapshoot. That can be a matter of there just aren't enough doctors. The waiting lists or the timeline is so long. So if you're dealing with whether it's situational depression or biochemical, you don't, and you guys, I mean, I'm on your side, but I heard you say sometimes it's just a matter of wait and see. It will sort itself out. I'm sorry, you can't really. I can't buy that, because when you're waiting for the psychiatrist, when you're waiting for the right fit, and you've been to a couple and it's not the right fit, and they're not getting it right, and it's not being resolved, and I'm not speaking, this is not me talking, this is just, we have family members. My sister-in-law took her life last year. I have my other sister-in-law's son is dealing with schizophrenia right now. He's in his 20s. We can't wait and see. How do you get the right fit? How do you get the resources? We can't wait the year and a half. You guys aren't there for us. I can't just come to you and say, hey, are you taking new patients? I just want to put that out there. I want to ask, we're saying there's a problem with, over-medication, and the right medication, the right amount. What's the solution? Is what I want to ask.
I think one of the things that, this only partially answers your question, but one of the things that drives me a bit crazy is in the organizations that I work with, and even in the governmental agencies that we deal with, you tend to take the view that mental illness is a short-term illness, and that we should be designing programs, that perhaps can manage high volumes but limited involvement, right? And I think one of the things fundamentally we have to do is take a serious look at the notion of applying short-term treatments or short-term programs to illnesses that are chronic, right? 98%, 99% of the children and youth I see have significant problems that have lasted weeks, months, years, right? And it drives me crazy that a young person that's been ill since the age of 12 and is now 16 and on several medications and still intermittently suicidal and self-injurious and really struggling, we're going to give this particular patient 12 weeks of our care, and then after that, well, I don't know, we'll try to figure it out, right? So, but that's an issue that needs to be addressed at a much higher level. One of the concerns, one of the issues in Canada is that Canada doesn't have a national mental health strategy. In Australia, as an example, in child and youth mental health, they have an organization called Headspace. And Headspace is tasked with providing services to all Australians in all states across the country. And to do that in a uniform way and to collect information across the nation. We don't have anything like that in Canada. The Mental Health Commission of Canada was established to begin to look at this issue. And it's a huge challenge. Michael Kirby, who headed the Mental Health Commission of Canada, said, you know, in medicine, psychiatry is the orphan of medicine. And in my field, child psychiatry is the orphan of the orphan. And so I think at a much greater level, we have to address some of these fundamental issues of how do we provide care.
Dr. Hatcher and then Dr. Bergeron.
Yeah, but the wait and see approach is really a reference to primary care, which you've already heard that phrase being used. It's not so applicable once you start seeing specialists. And it's the third debate really that we can have is how do you fix the Canadian health system, especially the mental health system. But we need to rethink what we do. And why can't you find out which psychiatrists are the best fit? Why can't we design a system where we could do that? That's an example of where perhaps we could use technology to do that, where we could get feedback from patients which would give you some help around knowing who would be the best fit. And I think, as Hazen said, we need to rethink in part what hospitals do. At the moment, they are not patient-centred. Their needs are very much focused on people who work in the hospital. If they're patient-centred, they'd be like libraries. In that there would be a resource centre where you could go along, you could pick out, well, I want a bit of mindfulness, some CBT, and somebody who knows about drugs, thank you very much. And maybe we should be rethinking hospitals a bit like that. That they are resource centres rather than something which is captured by professionals. And if there's one thing that I think you could do to try and change the system, and that's get patients far more involved in making decisions about how the system runs. It's absent in Canada compared to other countries.
Okay, I will be very short, very practical. I understand, but we are family doctor again.
Oh, yeah.
Okay.
Yeah.
Okay, so I hear family doctor, they are with patients, very severe, chronic depressed patients sometimes. And I believe sometimes that in 7-8 minutes, the family doctor can do much better than the psychiatrist 1 hour in his office along with the patient. Because they know the patient for a long time, they know the family, they know the situation. Anyway, to be very practical, in the province of Quebec, just on the other side, I work there as a psychiatrist, and we created something, I think, promising and quite cool. So what it is, all medical clinics are matched with a psychiatrist. And that's what we call a service of psychiatric répondant, so a psychiatrist answering questions. So the psychiatrist is available on the phone 5 days per week, and he is going to the clinic physically to talk about cases with the family doctor who have cases to discuss. And instead of sending 10 consultations sometimes just 1 out of 10 needs to be seen by a psychiatrist and his team because it's a very complex case. So with the feedback of a psychiatrist who is expert in mental health, with his background in pharmacology or the connection that he has to provide psychotherapy to a specific person. So this is very, very, very efficient, and we don't, we are not expecting the health system will change only with the politician, will come from us on the ground. And that's something should be done, I think, everywhere. Every medical clinic should be matched with a psychiatrist to discuss cases, and when necessary, a consultation. So that should help, and that could change drastically also your practice.
I'm going to have to apologize to the audience because I'm being given the hook. And what I'm going to ask our two last people is if they can actually approach the panelists during the mingling session that's coming in about 5 minutes. Would that be
Could
okay?
I say something?
I'd have to ask the audience. Because
Okay.
Is it okay? Sure. Okay. I like that.
Is one thing I agree with all of you is, but I don't know exactly how many years we have the MRI and how many now we have the helmet that they can study the brain. Before they couldn't study the brain. I have a friend that is bipolar, and bipolar is a very bad sickness. She went with electroshocks. And I started then to be very close to her because I was studying related with brain, many other things I was studying constantly. And she started to have a depression, and she was rocking in her chair. A person that could do everything. But then I started to notice when she got the electroshock and she really came out of the depression and was active again, I started to know how she was getting depressed. She was starting to be quiet, right. Then she was starting to not talking, and things like that. And this way I used to say, go to the psychiatrist, tell that you are not good, you are getting again depressed. And then she started to avoid going to electroshock, and many things like that. People doesn't accept that we have wrong things, like one other friend, I started to notice, just a minute, started to notice that he was doing wrong with everything. Finally, I sent him to the Dr. Frank, a clinical in memory, and they discovered that he had beginner Alzheimer's.
You've been very generous, and I mean that sincerely in sharing that story.
I think it's extremely important.
Yeah, no,
I agree with doctors here. I really feel good with all the research that you do.
Okay. Thank you very much, Matt. Thank you. Thank you very much. That brings us to the end. That brings us to the end of our session. We really should thank our panelists, our debaters, for being so generous.
Adrian, may I make just a comment before there's a vote? I just want to bring this back to the real purpose and the real reason that we're here. What you've seen and had a bit of a taste of tonight is our struggle to understand the human brain and the human mind. You know, we also have a great mission, and that mission is the field of neuroscience. And you heard a little bit about, from Adrian, neuroscience. You've heard about our great opportunity through the University of Ottawa Brain and Mind Institute. Our task here tonight as a start, as clinicians and as scientists, is to engage you and to engage and collaborate with each other to support the initiative of the University of Ottawa Brain and Mind Institute. And our ask would be that you join us in supporting the Brain and Mind by spreading the word, maybe even by emptying your pocketbook. But I'll leave that to Dr. Clark. It's been a pleasure. Thank you.
Desperate times, desperate times. If you haven't been convinced by the arguments so far, can I just refer you to that esteemed medical journal, the Toronto Sun? The headline on October the 10th was, "Beer is still safer to drink than water." For some reason I've remembered that one. And you know why? Because there's a finding of antidepressants in the water supply in Montreal and in Ontario. Now, if that's not a sign of an overprescription of antidepressants, I don't know what is. And the second question is, do you feel better? No. So they don't work either.
This is starting to feel like Ali Frazier. It's like a third fight. It doesn't end. Thank you very much. Thank you so much, everyone. So before I do the official thank yous, can we have a show of hands for those who side on this side? Agree with them. Okay. And then on this side. Clearly, the winners. I want to end because time is getting short and I want you a chance to mingle. So I want to end with a few housekeeping details, and that is, number one, when we end, we have to, and I apologize for this, take a few pictures. That will be short, and then you can approach and mingle and ask the questions of the speakers. I really want to thank all the panelists, in particular, I want to thank Adrian and Harewood. I really appreciate this, and we have a very small token of our appreciation. Every one of these members, panelists up here are amazing, and I just wanted to personally thank them all as well. Thank you so much. And of course, Richard and Pierre. I hope you enjoyed everything today. I find it absolutely fascinating. I do want to let you know that tomorrow is another event. It's the mini med talk, so basically topics on very hot topics like regeneration, consciousness, and genetics of neurological disorders. And finally, on Saturday, there is a celebratory event, at least it'll be for me, because I'll be drinking a lot of beer and relaxing. It is our gala. And unlike this event, it is not free, but please participate because it's going to be incredibly exciting. We do have the Juno Award, sorry, I thought I was an American there for a second. The Juno Award winner, Serena Ryder, who will be giving a 45-minute concert during that. That will be very, very exciting. Thank you all. So, without further ado, have a very good evening. Please stay and enjoy yourselves and just enjoy.